Hello, my name is Dr. William Salerno, and I've been asked to speak to you today about cardiovascular disease prevention and the Advanced Cardiovascular Assessment Program here at the Hackensack Medical Center, Heart and Vascular Hospital in New Jersey. I want to thank Dr. Perlo for inviting me to speak at the symposium again. It's always an honor and a privilege. So let's get going. Disclosures, I have none about this topic. Cardiovascular disease prevention. Better late than never. More important than ever, perhaps. 18 million people a year die of cardiovascular-related heart disease. 32% of all deaths worldwide. Cardiovascular disease, the global picture. Well, how is it? Not encouraging. Cardiovascular disease burden around the world is increasing. When we look at China, India, Russia, and the United States, the top 4 countries, the number of people dying of cardiovascular disease is steadily rising. 1/3 of deaths globally. There's an urgent need for countries to establish cost-effective public health measures to reduce cardiovascular disease and the burden of it. And it has to be an economic consideration. So when we talk about the slides that we're going to present, we're going to talk about 2 options here. One is preventative strategies in a cost-effective manner, and then the other is perhaps more an advanced strategy. And I'm not going to make the argument for either one, but I will just tell you that the simple things are the most effective and work very well. Well, what are the numbers? 85 million Americans have 1 or more types of cardiovascular disease. Peripheral arterial disease, more than 200 million people worldwide have peripheral arterial disease, more than 8 million in the United States alone. Unfortunately, this is greatly underestimated by the current criteria for peripheral arterial disease. Utilizing an ankle brachial index of 0.9 or less, we only look at the people with severe disease. So it's greatly underestimated. The average age of heart attack in the United States, 65 for a man, 72 for a female. Over 600,000 deaths a year related to cardiovascular disease. Atherosclerosis is far more common than we imagined. Could we treat things better? Let's look at the top indicators here. Hypertension, atherosclerosis in general, peripheral vascular disease, cerebral vascular disease, coronary artery disease management. Could we do a better job? Well, back in 2010, the American Heart Association came out with the simple 7. Let's look at diet, teaching people about their diets, avoiding smoking, weight control, blood pressure control, optimizing glucose levels, cholesterol management, and fitness. And touching on smoking, that means anything that's burning. Well, how well have we listened to the simple 7? What's our report card? Let's take a look at that. So let's look at diet, weight control, smoking avoidance, burning anything, optimizing glucose levels, blood pressure control, cholesterol lowering strategies, and fitness. How are we doing in the United States? Well, in the past 20 years in the United States, let's look at diet. Obesity has increased from 30% to 42%. Severe obesity, 4.7 to 9.2. Overweight or obese population now in the United States, close to 74%. Adolescents, 12 to 19, 21.2% with obesity. Children, 6 to 11, 20.3% with obesity. Our youngest, 2 to 5 with obesity, 13.4%. This is a real troubling statistic. What about smoking? Well, smoking cigarettes in general has gone down year after year, but there are new things in play here. We have vaping, which may increase actual smoking, and we have smoking marijuana now, which may lead to heart disease. And in one published study, myocardial infarction was associated with cannabis use, especially in young adults. So increasing cannabis use, especially from consuming it in a smoking fashion, may have implications for cardiovascular disease health. Well, who would have thought that? Another burning product. Diabetes in the United States, sugar control. Newly diagnosed cases of type 1 and type 2 diabetes have significantly increased amongst U.S. health. The youth in the United States are having more and more problems with regard to diabetic control. Ages 10 to 19 years of age, type 2 diabetes has increased for ethnicities, especially in non-Hispanic Blacks. Adults with prediabetes has doubled between 2005 and 2016. These numbers are likely underestimated and are very, very troubling. Blood pressure control in the United States. Let's look at that. Nearly half of adults, or 108 million people over the age of 50, If we look at the current guidelines of having a blood pressure between 100 and 120 millimeters of mercury systolic and a diastolic less than 80 millimeters of mercury, nearly half the population is in jeopardy. And the people that are taking medicines, 92 million, don't have their high blood pressure controlled properly. Again, staggering numbers. And again, just trying to keep the American Heart Association simple 7. Are we listening? Is our report card good? The answer is no. Well, how are we doing in fitness for our youth? There's no quantum leaps there either. Our fitness report card is fairly poor. Poor grades are especially for children that are in a socioeconomic compromise, children, minorities, and girls. We're not getting them enough physical activity. And that's a terrible report on our overall fitness in the United States. Well, what's the minimum needed for fitness? Well, let's keep it simple, without gadgets and gizmos. Pick an activity, anything you like, 30 minutes a day, 5 days a week minimum. But how hard do you push? Hard enough not to be able to have a chat with your best friend, but you can still breathe through your nose. You don't need to work out like those folks on TV who look like they're about to pass out and be resuscitated. We want you to exercise your entire life. We want you to have fun while you're working out, but we want you to be working out hard enough so that you can have a casual conversation with a person next to you if they were on the treadmill next to you or the elliptical next to you. That's pretty much moderate intensity. How are we doing with cholesterol in the United States? 29 million Americans have a total cholesterol level that's higher than 240, and 93 million over 200. A high intake of dietary cholesterol raises blood cholesterol levels, which are a major factor for cardiovascular disease. Well, we know this, but we're really not doing anything different. And I'm not going to get into health choices and food choices, but you have to pay attention to your diet. And you may not be the most popular person at parties, but you have to realize that diets that are high in cholesterol are associated with an increased risk of type 2 diabetes, liver disease, and cancer. Well, the solution is, and it's not going to be liked by all, is to go plant-based for protein as much as you can tolerate. Try to go entirely plant-based 2 to 3 days a week. And when you don't, you're allowed to have 1 kill a day. Well, what does that mean? That means you don't have bacon and eggs, bacon and sausage for breakfast. You don't have the tuna salad for lunch, and then a steak for dinner. If you're going to have 1 animal-based protein a day, it's once a day, not several times a day. So you have to keep that in mind. Do you already have cardiovascular disease? Well, there's studies to look for that. There's a numerous studies that we have available: carotid artery ultrasound, coronary calcium CT scanning, abdominal aortic ultrasound looking for atherosclerosis, femoral artery screening, ABI screening, arterial pulse wave velocities. These are all available. Some of them are commercially available where you can go into a parking lot at a shopping mall and have them done. But is it cost effective for global health care? So when we talk about global health care, that is, and you look at cost effectiveness, if you're in a budget of somewhere around $250 to $300 per person and you're screening a large population, that's going to turn into well over $200 billion. So that's not a cost-effective strategy. So when it comes to taking care of massive populations in a cost-effective manner, the American Heart Association, simple 7, wins all the time. Can you say a patient is a high risk because they have a coronary calcium scan that's high or low? Well, CT coronary calcium scanning is a great tool. And what does it mean? Well, some folks would say if you have a coronary calcium score of 0, you can get a 3-year warranty for having a risk-free survival. But in a high-risk clinical scenario, for an acute coronary syndrome, a coronary artery score can be 0 in 35% of the patients. So it's not 100%, and you have to take that in consideration. What about the folks that have a high coronary calcium score? Is that a bad thing? Are they in trouble? Are they going to die? Well, no. If you look at these 2 papers, these are excellent, and I would suggest someone or that you look at them. They're from JAMA Cardiology in January of 2019. High levels of physical activity and training and physical activity in association with a high coronary artery calcium scan may not be associated with an adverse prognosis. So that's something to keep in mind. Let's take a real case. So an 85-year-old female comes to our practice recently within the past month or 2 with fatigue and dyspnea on one, with having shortness of breath with less than one flight of stairs. So stress testing was out of the question. So we performed a CT coronary angio, and that revealed that the patient had a non-diagnostic lesion in the left anterior descending artery. And so we proceeded to obtain a heart flow study looking for fractional flow reserve by CT imaging modalities, and that suggested there was a high-grade widowmaker lesion in the left anterior descending artery. Now, as you see in the photos below, the images show that there's a high-grade lesion in the LAD and in the circumflex, and there's a successful intervention with angioplasty. But let's look at the coronary calcium score. The LAD had a coronary calcium score of 4.9, and the left circumflex had a coronary calcium score of 0. That's troublesome. So that means that you have to look at multiple modalities to see what's going on. And coronary calcium alone may not be the only answer, and you have to take it in conjunction with the whole clinical picture. Well, what does the United States Preventive Task Force say about all these studies and screenings? Based on what we had said before about the billions of dollars or hundreds of billions of dollars that it would cost to do it, what's the simplest reason, what's the most cost-effective way to do that? And probably the American Heart Association Simple 7 and following them. As we saw previously, our report card is not good. So perhaps that's the best way. But what about if we went a little bit further and we do provide these advanced services? What do we find out? Well, when we look at cardiovascular disease risks assessments and you try to apply these strategies to global populations, perhaps not a cost-effective method, but not all agree. The PISA investigators, for one, have multiple studies out showing that when you look at an asymptomatic population in the range of 40 to 54 years of age, and you use multiple imaging modalities, some of which but are not limited to ultrasound, looking at the carotid, the abdominal aorta, iliac and femoral arteries, you find out that asymptomatic atherosclerotic disease is present in 63% of the participants, 71% of males and 48% of females. Not rare. Well, you already have disease. Well, if you go back and look at routine imaging that has been done on your patients in the last 10 or 20 years, and you look at CT scans and look at the coronary arteries, and you look at other major arteries in the blood and in the vasculature, if you find coronary calcium and atherosclerosis already, you have your diagnosis. You'll likely see that it's been there many, many years ago. So you should have intervened earlier. Well, our ACAP mindset at the Heart and Vascular Hospital is showing an education of patient about their body's current status. And we think that that helps gain compliance for the medical treatment that will follow. And that's always been the problem, is getting compliance. Once they understand how their body is changing and understand that conditions already exist in their body, there's a paradigm shift in their health interest and behavior. Now this becomes a sustainable partnership with the patient and the doctor. The ACAP strategy at the Heart and Vascular Hospital is early disease detection using multiple imaging modalities and integrating them in an aggressive management fashion thereafter. Obviously, lowering the LDL cholesterol is important. We target the LDL less than 70 for most patients with advanced disease burden and less than 100 in other patients. We use markers such as LPA, ApoA/B ratios as some of the tests to risk stratify our patients. We encourage plant-based protein diets. And of course, using the AHA Simple 7 is priceless. When we look at the ACAP strategy, we find, again, that what if you already have problems that you didn't know about? Does it change anything? What if you have structural or vascular heart disease that you didn't know about? Does it change anything? What if you have other life-threatening conditions? Unfortunately, you may have these things already. And when we study the cardiovascular system, we find severe valvular lesions and cardiac conditions that require intervention. We find renal masses and tumors, abdominal aortic aneurysms, liver lesions and fatty liver, all too common. Adenopathy in places where we are looking at the vasculature, which subsequently lead to diagnosis of other diseases. And again, when we look at the abdomen and pelvis, we're finding diseases in other organs. And we find, obviously, in the carotid assessment, thyroid lesions and thyroid cancers. The ACAP program essentially is finding cardiovascular disease early. We're intervening aggressively and treating other diseases when present. We're providing focused care beyond what's expected. When studying the cardiovascular system in detail, we find things unrelated to cardiovascular disease that can be treated early, positively impact on a patient's health, and in some cases, save a life. As in previous years, this year alone, we've had several patients saved by detection of asymptomatic cardiovascular disease and incidental cancer. And thank you for allowing me to present at this year's symposium.